All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Our topic today is at the intersection of cardiology, palliative care, and ethics, with ethics of LVAD deactivation. Our outstanding and wonderful guest today is Dr. Sarah Hull. Sarah is a board-certified cardiologist whose clinical practices focus on echocardiography and cardio-oncology. She's the cardiology course director at Yale School of Medicine, where she also serves as associate director of the program for biomedical ethics. And her recent scholarly work is quite diverse, but the two I find most fascinating are her focus on ethical issues involving DT-LVADs and patients with recurrent injection drug use related endocarditis. Our format for today is kind of going to be two-ish parts. We're going to have a dialogue, and then at the end, we'll also open it up for any other additional questions that come up. So, Sarah, welcome, and the floor is yours.
Awesome. Okay. Well, thank you so much for the very kind invitation and introduction. I'm really excited to be discussing with you all today. As many of you probably heard, if you were on when I came on, 5 minutes ago, I'm not going to use the PowerPoint because I think it tends to have a conversation stifling effect. And so I'm just going to talk. I would encourage you, I do have some notes on my computer that I'll be looking at. And but if there are any questions that anyone has as I'm talking, I really would encourage you, or even if they're not questions, even if they're comments, things that you've seen, things that you feel that need to be added, please by all means just chime in and interrupt. It's not an interruption, it's a conversation. And so, I think that I enjoy giving these talks because not just sharing knowledge, but gaining knowledge. It's really, bi-directional. And so, I'd love to learn from all of the diverse perspectives that I'm sure are represented here. So, with that being said, I will get started. So, as you heard today, I'm going to talk about some of the ethical considerations in the deactivation of left ventricular assist devices, or LVADs. I don't have any conflicts of interest to disclose. I will note that I'm speaking about what I'm speaking about today is mostly content taken from a paper that I and colleagues published in JACC Heart Failure last year. And I'd be happy to share that paper via email, or Marty, I'm sure you have that. That's why you reached out to me. So, but if anyone doesn't have it and needs access to it, I'm happy to provide that. So briefly, my objectives for today, the things that I'd like to discuss. First I'll start with a very brief review of the background of LVADs for destination therapy in particular, and what that means. Then I'd like to spend a little bit of time talking about device ontology, or the nature of being, and how this may inform the ethics of device deactivation or withdrawal. And finally, I'd like us to talk about best practices in approaching patient or surrogate requests for device deactivation, particularly in regard to both respecting patient autonomy and also mitigating the moral distress of clinicians. So with that being said, I'll dive right in to some very brief background. So left ventricular assist devices, or LVADs, as I mentioned, have become increasingly common. There have been nearly 20,000 total implanted in the US, and nearly 2,000 a year currently. And so this is something that when it originally was introduced, it was sort of very niche. It's still certainly, in the realm of advanced heart failure and requires dedicated training and dedicated experts to take care of, but it's not the rarity that it once was, certainly. LVADs were initially developed actually in the 1960s as a bridge to recovery, or a bridge to transplant. So meaning that they were initially developed not intended to be permanent implantations, but rather to either help patients recover and then have the LVAD explanted, or if patients were not able to recover, the LVAD was intended as a temporary device in order to bridge patients to transplant. That changed about over 20 years ago. It's hard to imagine it was that long ago. But in 2001, a landmark trial called REMATCH was published, and it compared LVADs as destination therapy, meaning that LVADs were no longer sort of a means to an end of recovery or transplant, but actually became an end in themselves. So that's what what we mean by destination therapy. Some people argue that the term DT should now be termed durable therapy because destination sort of has a finality to it, and durable better describes the actual day-to-day living with an LVAD. But regardless, DT or destination therapy is still the most widely used terminology. And so the REMATCH trial compared LVADs as destination therapy, meaning patients who were not expected to recover and who were not candidates for transplant, comparing this with optimal medical therapy. And they found that LVAD DT improved both quality of life and reduced all-cause mortality by 48%. And so that really began to usher in the era of left ventricular assist devices for destination therapy. Sorry, excuse me, my throat is a bit dry, so I need to make sure that I don't lose my voice. So the earliest devices that were used for destination therapy were quite bulky and quite risky. They carried risks of pump failure just because of the device mechanics, thrombosis or clotting within the device, stroke, GI bleeding. But as these devices have evolved, the later devices pose much lower risk, and patients are actually living a lot longer with them. So we're seeing this evolve from, kind of an end stage measure meant to improve quality of life and reduce mortality, but still something that was being offered to very sick patients, to now something where it's almost like comparable to sort of a chronic disease state where we see patients living many years often with these devices. And as a result of all of this, LVAD for destination therapy now actually accounts for majority of LVAD implants altogether, over 80%. So it's really been a huge paradigm shift in how these devices are deployed today. So with that being said, then I'd like to talk about, again, since we're focusing on devices, let's talk about how we can think about the ontology or the nature of being of these devices, because there are a lot of different medical devices, obviously, and thinking about the ethics of whether or not you can explant or turn them off or withdraw them in any way is very much tied to, well, what is their nature of being and what is their nature of interaction with the patient. And so there's sort of multiple axes that we use to think about device ontology. One of them is external versus internal. And so that's relatively intuitive, right? So, a ventilator would be an external device. Dialysis is external versus something internal, which is implanted, like a pacemaker or a defibrillator. Then there's also the regulative versus constitutive axis. This maybe requires a little bit more explication. So regulative devices are in devices or interventions. It doesn't have to be a device, it can be a medication. These are interventions meant to restore homeostasis versus constitutive devices, which are meant to maintain homeostasis. So to think about an example in external devices, for example, a regulative intervention, again, this is not a device, it's a medication, but could be something like amiodarone. So amiodarone is meant to restore the homeostasis, in this case, of sinus rhythm. If you stop amiodarone in a patient, assuming they're not acutely ill and, very likely to go into atrial fibrillation if it was acute illness, let's say sepsis that precipitated in the first place. But let's say a patient is admitted with septic shock, develops atrial fibrillation in that setting, they're started on amiodarone, and then they're continued on it. If you were to stop amiodarone, it's very possible that they would stay in sinus rhythm. They wouldn't necessarily go back into atrial fibrillation because it's meant as a restorative intervention rather than a maintenance intervention. Some patients who are at very high likelihood of having recurrence often will be maintained on amiodarone, but the nature in itself of that intervention is more of a regulative one. Versus constitutive interventions, again, externally, a ventilator or dialysis. If you have someone with respiratory failure that requires a ventilator, and you withdraw the ventilator, they're going to very quickly develop respiratory issues as a result. It's not something that just restores, it's necessary to maintain. Similarly with dialysis, if you dialyze someone once and then you do not dialyze again, unless it's, a very temporary kidney injury, in someone with chronic kidney disease, they're going to require maintenance dialysis rather than one-time dialysis. Whereas again, a single bolus of amiodarone in a critical care setting can sometimes be enough to convert someone to sinus rhythm, or a drip for a certain amount of time. So is that distinction clear before I move on? I just want to make sure, because I know that, all right, I'm seeing some nods and I'm not seeing hand raises. Okay, cool. And then finally, there's a further distinction of substitute versus replacement therapies. And these are both, substitute and replacement are subsets of constitutive therapies. And so, an example here would be a constitutive therapy that is a substitute would be something like a pacemaker. And so as compared with an ICD, for example. So a defibrillator is also a regulative device. It's an internal one, but a defibrillator isn't constitutively active. It's only there to shock someone if they develop a ventricular arrhythmia, as opposed to a pacemaker, particularly in someone who has sick sinus syndrome or other conduction abnormalities. They may be pacemaker dependent and need that pacemaker all the time. And even if it's not always active, it's always, kind of ready to kick in, although hopefully a defibrillator is as well. So a pacemaker may act as more regulative in someone who has only very intermittent conduction disease, but in someone with more severe conduction disease, a pacemaker is going to be something that is constitutive. And we would describe that as a substitute because it's something that is dependent. It's dependent on a battery. It's dependent on external programming. If the battery runs out, it stops working. As opposed to a replacement constitutive therapy. And that would be something like a kidney transplant for end-stage renal disease, or a valve replacement in someone with, let's say, severe mitral regurgitation. And so those therapies really do work independently. They don't need to be programmed. They don't need batteries to be changed. Once they're in, they really integrate themselves fully within a patient's own physiology and become part of the patient in a way that is sort of inextricably linked to their native physiology, and isn't subject to external programming. So is that distinction also clear? Okay, great. And so I think that's relevant with respect to LVADs. I think it's a helpful framework to think about LVAD deactivation, because of comparing and contrasting the ethics of withholding or withdrawing intervention sort of along this gradient. So I'll talk about very briefly, examples here where I think there's sort of a gradient from very ethically permissible to ethically permissible, but maybe emotionally challenging, to ethically impermissible when it comes to withholding and withdrawing interventions. And so, withholding interventions, that's sort of the least debated, although there can be debate there. Withdrawing external interventions, usually thought to be very ethically permissible. Withdrawing internal regulative interventions like deactivating an ICD, very ethically permissible. Withdrawing internal constitutive substitute interventions like a pacemaker, that's something that typically is not done, and would often make individuals quite uncomfortable, but it may be ethically permissible if the right conditions are met. And then withdrawing internal constitutive replacement interventions, such as explanting a transplanted kidney or removing an implanted valve, typically that is not considered to be ethically permissible, because that itself would be the precipitant of a patient's death. So, that's sort of the spectrum that we have. So I'm going to touch on those examples in a little bit more detail. I'm trying to keep an eye on time, because when I've given this talk before, it's been an hour. We're okay? All right, we're okay. All right. So withholding interventions, as I mentioned, so when withholding interventions, Rarely is that controversial when everyone's on the same page, but there can be controversy when it comes to withholding interventions when there are disagreements between a patient and surrogates. And so, of course, if you know if a patient has capacity, of course, we need to prioritize what the patient's wishes are. But, that's as clean as that is on paper. Sometimes it's not always clear cut, as I'm sure you all know in practice, where a patient may be expressing a lot of reticence to withhold a certain intervention that they feel may be overly aggressive, but their loved ones who have power of attorney, even if that power of attorney isn't relevant while the patient has capacity, they may feel very differently and feel like they aren't ready to, quote, let the patient go. They want to be more aggressive than the patient. And so sometimes withholding interventions can still be a fraught decision, but it's not something that I think as clinicians, we typically feel very ethically conflicted about, although there are exceptions to that as well. So, it can be challenging for us when it clearly violates the best interest standard. So, for example, let's take a 50-year-old, perfectly healthy, otherwise man who presents with an ST elevation MI, who says, well, I don't want to get a cath because I'm afraid of needles. I don't think that most people would be comfortable saying, well, we have to respect his autonomy. He doesn't like needles, so we're not going to offer him this life-saving intervention, even though his life expectancy would be decades and decades. Certainly we don't coerce patients, but we have to ensure that a decision is informed, and so there's really an important duty on our behalf to confirm that patients truly understand the implications of their decision, and to make sure that they have decision-making capacity when they make decisions that most reasonable people would not make, and or we suspect that they may not have full decisional capacity. And you can argue, well, isn't that a little paternalistic? And yes, I suppose that is. Paternalism is a very morally loaded term in and of itself, and it's sort of a morally loaded way of saying beneficent. But we're not just offering a menu of options from which patients can choose. We really do have a moral obligation to make a recommendation when there's clearly a better or a worse path that the vast majority of patients would take. So while, we shouldn't use coercive language or behavior, there is a really strong duty to make sure patients are informed and have capacity when making decisions like that. When it comes to withdrawing external intervention, so we talked about withholding and how that's not typically a difficult decision if everyone's on board. And again, by its very nature, LVADs aren't offered to patients unless they have very advanced heart failure. And in those cases, if patients and surrogates say, well, that's not really within my goals of care, I'd like to focus more on comfort measures and I don't want aggressive measures, that's very reasonable. And so we're very comfortable withholding an LVAD if that's not something that a patient or surrogates want. When it comes to withdrawing external interventions, there's really, generally there's consensus that there's a minimal ethical distinction between withdrawing and withholding external interventions, and withdrawing and withholding in general, provided, of course, that withdrawal, as it typically does, leave the patient in no worse condition than if the patient had never received the intervention to begin with, right? Because that, therefore, then implies that we're really allowing the underlying disease to progress, rather than being a direct causal agent of disease progression or death in some cases. Also, external interventions are usually administered in the medical setting, and they're easily separated from patients. And so that's another thing that makes that not very ethically challenging. LVADs, of course, are actually kind of difficult to categorize along the internal and external axis, as they really share properties of both, because they are internally implanted. But unlike a pacemaker or defibrillator, for example, which is completely confined underneath the skin barrier, LVADs, of course, have a drive line, so they're externally powered and controlled. Again, ICDs, pacemakers have an internal battery that can be controlled remotely, but there's not a direct line into the patient. So LVADs have internal and external aspects, and so I think that axis is less relevant for considering their deactivation. So what about withdrawing internal regulative interventions? So again, internal interventions that are meant to restore rather than maintain homeostasis. So that can seem more emotionally challenging when the device is internal. That's been described by some ethicists as the biofixtures argument, because again, sort of symbolically, when something is within us, it feels like it is more a part of us rather than something um, that's been given to us in a medical setting by others. There's a more self aspect and a less other aspect of it. But that being said, again, I would argue that it's not really ethically distinct if it leaves the patient in the same condition as if they had never received it. So CD, that really the patient is in no worse condition than if they had never received the defibrillator. In both cases, it's really not changing their day-to-day functionality. It's just that, they won't receive a shock if they have a ventricular tachyarrhythmia in both of those cases. So how is this relevant to LVADs? So you could argue that LVADs might fall into this category when they're used as a bridge to recovery. But, otherwise, LVADs are probably more thought of as a constitutive therapy than a regulative therapy because they're not really restoring, they're more maintaining homeostasis in either until a more definitive intervention, such as a transplant, or until or as destination therapy where they're meant to indefinitely maintain. And indeed, when LVADs are used as a bridge to recovery, they are in fact not only deactivated, but explanted if a patient has full recovery. So, the ethics of that are very different than when used as destination therapy. So withdrawing internal constitutive interventions. So, this is where I think people, both ethicists and clinicians, can become a bit more uncomfortable. Because if you withdraw a substitute device, such as, and again, we're talking about substitute. I'll talk about substitute devices first, such as a pacemaker. And again, remember, a substitute is dependent on battery power. In this case, it's a substitute because it's dependent on battery power and native myocardial conduction. It can't work independently of other inputs. It can feel more emotionally challenging, especially when it would precipitate death. So if someone's pacer dependent and you turn off a pacemaker, it's very conceivable that that could be at least temporally the precipitant of death. Although it again, if the patient had never received the pacemaker, it's not necessarily going to leave them in worse condition than withdrawing the pacemaker will not necessarily leave them in a worse place than if they had never received the pacemaker. If they're truly pacer dependent, they may not have lived that long to begin with. But that being said, there's going to be a little bit of a higher bar there because it's really important to understand, well, what's the patient's rationale? Because a pacemaker doesn't typically cause pain, and it doesn't interfere with the dying process either, because when patients, during the dying process, as there's, metabolic dysregulation, you actually lose pacer capture. So having a pacemaker in does not interfere with the dying process. It doesn't cause pain. And so it's really important to understand what the rationale would be before you would go ahead and just sort of knee-jerk deactivate it. And also I think, there's more room here for conscientious objection on behalf of the clinician if they're truly uncomfortable with it.
Sarah,
yes.
could I jump in and ask
Yes,
a
please.
slight
Yes.
tweak?
Mm-hmm.
Would cardiologists feel different for cases where they have caused the heart block because of ablation? Does that add to it? Because I think those are
That's
the
a great
cases.
point.
I'm curious what your thoughts are on that.
I think so. I mean, I think that I think certainly if it's an iatrogenic, so an AV nodal ablation, for example, for difficult to control AFib that has failed multiple AFib ablations, and so they've just decided, okay, we're just going to do AV node ablation, anticoagulation, and ventricular pacing. Yeah, I mean, I think in that case, I do think that the ethics become a lot more challenging, and I think that even in the case where it is just native pacemaker dysfunction, I think in many cases, clinicians are going to feel very uncomfortable with that because of the fact that it would precipitate death. And I think that, before you would go ahead and just, again, for example, comparing with deactivating an ICD, that can interfere with the dying process and it's very uncomfortable. And so that's very non-controversial. Deactivating a pacemaker, I'm hesitant to say it's going to be, it's not ethically permissible in any case, But, considering the gravity of it, particularly if it is something, if the ablation was done by a physician, and so it's an iatrogenic conduction deficit, I think a lot of cardiologists and ethicists might have a very reasonable ground to stand on and say, no, actually, I'm not morally or ethically or clinically comfortable with deactivating this, because I would be the precipitant of this patient's death, and this would be hastening death. This would be causing death. This in my mind is morally akin to, or ethically akin to, euthanasia, and I don't feel comfortable doing this. I don't feel that this is ethical, and I think that there's a real that's a very sound argument that can be made, and so I think for that reason, in most cases, pacemaker deactivation is not something that clinicians or ethicists will feel comfortable doing. But if it, perhaps you can imagine a patient who is extremely ill, and has no quality of life, no interaction, has clearly articulated their goals, that they wouldn't want to live in a certain way, but they are not actively dying. When they got the pacemaker, they even said, listen, I want you to turn this off if and again, as we know, and we'll discuss later on, we're usually very bad at predicting the exact situations in which we will be. But my point being is that, while it's going to be very rare that a request like this makes sense medically and ethically, it's hard to say, it's never going to be ethically permissible. You can imagine perhaps a state in which it may be ethically permissible to turn off the pacemaker, although it's going to be a challenging decision. And I think many would be quite uncomfortable with it for that reason. And your wrinkle makes it even more problematic, because that standard that we can feel good about, that it will leave the patient no worse off than if they had never received it, that throws a wrinkle in it. Although, to be fair, pulmonologists will say, well, if someone's been on a vent for a long time, they can develop respiratory muscle weakness. And, so in fact, they may be worse off in a way than if they had never received it. Although the counter argument to that is, well, but they needed it in the first place, and they probably would not have survived if they had not been intubated and ventilated in the first place. But the point being is that that's something like very neat and tidy that we can sort of rely upon for moral reasoning, but it may break down in other circumstances as well. And it's, as moral reasoning is not always neat and tidy and separated into neat little boxes. And I think LVADs really illustrate this point. Sorry, you're going to say something else.
Well, I was, because I think it's so interesting that if you get 100 cardiologists in a room and ask them about this heart block question, I think a majority would feel a lot of controversy and reluctance to turn it off. But I bet if you got 100 palliative care clinicians in a room, I bet the exact opposite would happen. I would say a vast majority would say, of course you can turn it off. It's an artificial tool. And so it's so interesting, because the thing that worries me is that a point that you made in your paper is that cardiologists and palliative care physicians think about some of these things differently.
Yes.
And you also made another point where, for some things, palliative care clinicians are very unified. And so there's a worry that if you just get palliative care people together to talk about some of these controversies, you get an echo chamber.
Yes.
And that's another reason why I'm so appreciative of your paper and you being here to offer, I think, a perspective that sometimes we don't know that we don't know, and have some blinders to.
Well, thank you. And I have to say, I mean, I feel the same way about working with palliative care specialists, because I think we also get in an echo chamber as cardiologists. And that's absolutely why, when creating policies, and again, this is not something common enough that often there aren't really, clear policies around this, but that's one of the most important reasons why, when creating ethical policy, it's really critical to get the input from different stakeholders. And that means different clinicians in different areas of specialty with different levels of training, and, and patients as well, because we all have our blind spots, and, and we're all of us have our biases. Bias is an inherent part of the human condition. And actually, the person who thinks that they have no bias is the person I'm most worried about having bias.
Right, right.
Right? Like we all have bias. That's how, we evolved to have biases to, to make shortcuts and to be able to make quick decisions. And, it serves us well. When we see the tiger and we know we need to run from it because we don't want to be its lunch. But it doesn't always serve us well when we're trying to make thoughtful, ethical decision making and putting ourselves in other shoes. So, I think that's a really good point. I'm gonna, is it okay if I talk a couple more minutes? I know we're kind of coming at time.
Please enjoy.
Okay.
We'll take you as long as you want, and we'll.
Okay, great. Yeah, if people need to leave, I certainly understand.
Yeah.
And so, just then finally, talking about withdrawing these internal constitutive therapies, we were talking about the substitute devices, replacement therapies, as I mentioned before, like a valve replacement or a heart transplant. No, I think even palliative care docs would not say, oh, let's go ahead and do a surgery to like remove the transplanted heart or kidney or remove the transplanted valve. That's, once you have that, like that, there's pretty much broad ethical consensus. No, we don't do that. That is precipitating death. And so, and I think the reason this is so important to think about with LVADs is because, upon initial implantation, you could probably argue that they function more as a substitute therapy, because they are more, there's still some native function, and they're working more with that patient's native heart function. But as patients evolve and physiology evolves in response to the LVAD, it almost evolves into more of a replacement therapy. And in particular, when you deactivate an LVAD, you do pretty clearly leave the patient in worse shape than if they had not received the LVAD. It changes LV geometry, so it changes function just by nature of putting something non-contractile like the cannula into the LV apex. You've got this separate circuit where blood can pool and thrombose. It often causes remodeling that leads to aortic regurgitation. And so there are clear physiologic changes that happen after LVAD implantation. And so someone who's had a long-term LVAD, it probably, can arguably be viewed as a replacement therapy. And that's why I think a lot of clinicians do feel, very, very torn about whether it's ethical to deactivate. And so, and I think very interestingly, to your point, about, deactivating the pacemaker in this case and how cardiologists and palliative care docs, and other specialists, other clinicians might differ. There was, in our paper, we talked about how members of, different societies, including the European Society of Cardiology and the Heart Failure Association, the International Society of Heart and Lung Transplant, Heart Failure Society of America, and the American Academy of Hospice and Palliative Medicine were surveyed. And in fact, 60% of cardiologists versus 2% of hospice and palliative medicine clinicians believe that patients need to be imminently dying before deactivation of LVADs can be ethically be considered. And 13% of cardiologists believe that LVAD deactivation was akin to euthanasia, while 100% of hospice and palliative care medicine clinicians believe that death after deactivation was due to the underlying disease. And I mean, I think the reality is quite messy in that it's kind of both, right? And that it's very hard to neatly separate those things out. And that's why it's ethically challenging, right? Like if you remove a transplanted heart, like obviously, like that's one very clear cause of death. If you deactivate an ICD in someone who's already prone to ventricular arrhythmias, it's obviously letting the underlying process take its place. And here it's messy and it's not clear, and it really depends on perspective. And so for that reason, we propose, rather than, sort of weighing and saying, yep, it's, definitely ethically permissible, or nope, not ethically permissible, realizing it's going to be very contextual, depending on the patient, depending on, most importantly, the patient's goals and values, frankly, that should always be central. But, also the surrogate and family members, when patients can express their wishes, because they're the ones who are dealing with the moral weight of decision-making, and they're going to be dealing with the emotional aftermath of, whether or not they experience that as a good death for the patient. And so while obviously, we don't want surrogates to override patient wishes, taking into account their concerns is an important part of ethical decision making at the end of life. And then also clinicians and making sure that, you know, we're not leading to undue moral distress in clinicians, realizing that, again, we have to center the patient, but, you know, as moral agents, clinicians not feeling like they are killing patients, it is a really important consideration that we need to take very seriously. And so, you know, we talk about sort of a 5-pronged framework addressing advanced care planning, capacity assessment, weighing terminality, clarifying alternative options, and of course, palliative care integration. And so I'll say a few words about advanced care planning. I'll talk for 5 more minutes and then I promise I'll stop. So that's just 10 minutes over, not terrible. Pretty par for the course for me, actually. So pre-implantation counseling is really key here. And, you know, there's been more written recently calling into question the value of advanced care planning, you know, because when you look at it empirically, it's not clear it actually improves outcomes or relieves distress. And really because of the limitations of what's called effective forecasting, or the fact that, you know, we're very poor at predicting how we would feel in the future under different conditions. And so, you know, that's been well documented, for example, in the disability literature, and actually explains a lot of why there's so much rampant ableism, not just within our society, but particularly within the medical field, because typically, you know, we tend to disproportionately value functionality and productivity. Like those are big values that we hold in the medical profession, and that's a good thing in many ways. That's a positive, but you know, there can be a negative side of that, where we may overestimate how devastating it would be to lose a certain amount of functionality or to, you know, lose a degree of productivity. Whereas in fact, the data show that, you know, when people suffer injuries that lead to disability, often they actually acclimate pretty quickly. And, you know, patients with long-term disabilities often are more troubled by the lack of accommodation to their disability than their disability itself. And so, you know, and this applies to advanced care planning as well. Often people think, well, I would never want to live like that. But then when that happens, like, well, I actually still really get a lot of meaning out of, you know, these other aspects of my life. Or conversely, someone might think, no, I want you to do everything, like, don't give up on me. And then realize that how difficult something is, and might say, you know what, I think it's time to reassess goals. So we're not good at predicting. And so I think what's really critical is, number one, avoiding checklists. You know, not saying, well, you know, in the event of this, would you want CPR? Would you want to be intubated? Like, it's very hard to predict that. And a lot of people will say they don't want those things. They don't want life support, but actually what they mean is, like, they don't want prolonged life support if there's no chance of recovery. But if they have pneumonia and they're going to recover in 3 days and they need to be intubated, like, of course I want you to do that. And so, you know, the avoiding the checklist and really rather trying to understand, like, what are their goals, their values, their priorities. It can be helpful to describe certain situations as an example, but really more get to the point of, like, you know, what is a good life to you? You know, what are the things that you value the most? What gives you the most meaning and the most purpose? And, you know, thinking about potential situations, but recognizing that it's going to be impossible to predict how someone feels in the future. We're just terrible at that, as you know, as humans in general, and you know, as medical professionals, we're not particularly good at that either. And it's also important not just to appoint a surrogate decision maker, because we can't predict, but also to include the surrogate decision maker in those initial discussions so that they feel empowered to use that substituted judgment standard when making decisions for patients when they're not able to make it. And then also, it's important to anticipate concerns regarding conscientious objection. So, you know, if a patient is being seen by a heart failure specialist who really does feel that LVAD deactivation is akin to euthanasia, which I think is, you know, a very valid argument, even though it's not one that's going to be shared by everyone, I think that needs to be disclosed. Just so that, you know, there's understanding that, you know, that's something that, you know, this cardiologist may not feel comfortable doing. But, you know, talking about, are there other cardiologists, you know, on the team who would feel comfortable if that's an option that patients would want on the table. Just, you know, making sure that everyone's sort of values are on the table, and that it's a really open and honest discussion. You know, with respect to capacity assessment, weighing terminality, and clarifying options, again, you know, there needs to be a higher bar for capacity assessment when the stakes are higher. But, that doesn't mean that just because you don't agree with me, you can't possibly have capacity. And so I think we do need to be careful of that distinction. It's obviously important to evaluate for reversible factors if patients make a request for device deactivation, like depression. But again, we have to avoid the tautology of, well, of course you're depressed, that otherwise you wouldn't request device deactivation. So again, we need to have some humility and be careful to avoid those tautologies of, well, you don't agree with me, so you can't have capacity. You don't want this life-sustaining measure, so you must be depressed, like that. And those are really important pitfalls to avoid. And then exploring alternative options. Is someone's request for device deactivation really, just a fact of related to the fact that they've had inadequate pain control or control of other symptoms. And then finally, the final recommendation of our framework, which is an apt point to stop here, is that, palliative care integration is something that we should be doing early and often, not just to mitigate symptoms, but also to mitigate the psychosocial distress of end-stage illness, and as the dying process begins. And, I'm preaching to the choir. You all are really good at this. And I will say that I've tried to make talking about death, an important skill that I've tried to hone. But I will say that, it's not something that I do on a day-to-day basis. And it's not something that my specialty has traditionally always done very well. So there's a lot of room for improvement. And, I think that we really, again, need to have humility and recognizing our limitations as clinicians, and that, sometimes we need to bring in the experts in other areas, such as palliation. Especially because I think that, as I mentioned earlier, we with our rescue ethos and the fact that we tend to really overvalue technology and undervalue care, in sort of the American medical ethos, I think that it's really important to make sure that we recognize that the importance of care, and that the technology that we use is really not going to provide patients with the relief and quality of life they seek if they're not getting care that's commensurate with that. So on that note, I will end. Sorry I went over, but I really, really appreciate your time and attention. I'm happy to stay on even longer for questions if people want to discuss. I don't have any other immediate obligations, although I, of course, want to respect your time. And I know I've already taken more of it than I said I would.
No, absolutely. Well, in just a moment here, I know Sarah Peppers has got a question. I just want to let you know that later this fall, Jody Halpern, she's a professor of bioethics at Berkeley. She has spent her career studying affective forecasting errors, and I'll send you the recording of her episode when she comes on later this fall. I think that you would appreciate that since it's
please
so relevant.
do.
Yeah.
Oh, I'd love that. I would love that.
All right, Sarah, why don't you finish us up?
Hi, Dr. Hall. I'm Sarah. I am
Hi.
embedded in the heart failure clinic as a palliative nurse practitioner, and I also have a background in cardiology before that.
Amazing.
But part of my job is to have the preparedness discussions with our BTT and DT LVADs. Going to have two right after this. I agree with what you said about it not being a checklist and rather being like, what is your minimum acceptable quality of life as you can tell right now? And also the other thing that you had mentioned about there's a difference between doing everything because the doctors think you're going to recover versus doing everything when they don't think you're going to recover. And how would you feel about that? And having more of kind of like a broad conversation than that checklist. I love how you brought that up. But I loved your paper. It was so great.
Oh, thank you.
I will confess to you that in our preparedness discussions, we do not routinely discuss what it will be like to possibly deactivate the LVAD. And I think it's for a few reasons. One is that a lot of our palliative discussions are kind of guided by patients' readiness to discuss the hard topics. And often at the point of their implant or the pre-implant, they're feeling very hopeful. A lot of them are hoping to not even need the VAD. They're hoping to qualify for direct transplant or BTT. And I think a lot of it is the forecasting thing too. Like you said in your paper, they're surviving so long that they might have totally other different processes that come.
Absolutely.
Whether it be their lungs or cancer that happens, and it's so hard to predict what the end of their life will be like. So we definitely touch on it if we can sense that they're ready for that kind of information, but it's not routine. So my question would be, at what point do you think it's most appropriate to really spell out what a deactivation might look like?
Yeah. I mean, that's a really great point. And, I think once again underscores the importance of having input from people in the field doing the work. Because as I mentioned, my clinical area of expertise is cardio-oncology. So, these are not patients that are typically getting LVADs. Although I did work with these patients in residency and fellowship.
Sure.
So, I think there's not going to be a one size fits all time. And certainly I think it's very fair to say, if there's a concern that bringing this up is going to cause harm to the patient because of distress that it's causing, then I don't think we're helping patients if we're causing them a lot of distress. Although I will also say that I think sometimes we tend to worry about, we think we're worried about causing patients distress, but what we're actually worried about is causing our own distress.
Yeah.
And I'm not saying I don't think that's what's going on with you. Like it's it's very obvious just from hearing you speak already. It's very obvious that you are having really thoughtful conversation. I love the way that you framed it too. Talking about, would you want everything, if we think you're going to recover versus not recover? Like, it's clear that you've thought a lot about the framing. I actually really like that. And I may borrow that if that's okay.
Oh, sure.
Because it's a very patient-friendly way of sort of framing that. So, I think that earlier is going to be better. But recognizing that things will change, but more just so patients have an idea of, what could potentially happen when going through this, because what is the endpoint going to be if this is intended? And again, it's also different if they're receiving an LVAD and the intention is as a bridge to transplant. I think that discussion is a little bit less relevant than if it's implanted with an intention as destination therapy. Certainly it's not to say it's irrelevant. And sometimes bridge to transplants end up evolving into destination therapy.
Yes,
but
we definitely talk about that.
right. And I think at that, if that's the case, once it seems like, okay, we're probably not going to go the transplant route, and it's more likely this is going to become destination therapy. Maybe that's the point at which it makes sense to introduce that discussion. If it's being implanted as destination therapy, it's probably, again, it seems that it would be ideal to at least broach the topic, even if there's not agreement on the topic, but just to say, this is something that you might want to think about because, here are concerns. And, here, something to think about is this, describing, what that looks like at the end of life, because, this is something that you're probably going to live with for the rest of your life. Without being overly prescriptive, without being trying to overly cover every base. Sometimes just planting a seed can be helpful, but again, there are also times where it's very clear patients aren't ready to hear, like there's just too much going on and you just have to wait, and that's okay too. But I think it's, go ahead, sorry.
Oh, I was going to say, something we've noticed in the pattern of our DT patients especially is that we'll see them during preparedness discussion, and then they get their LVAD. Things are going well for a long time because the LVADs are working great now. And we don't meet them again until they're doing very bad and death is more imminent. Something we've been trying to talk about more is in our clinic that we should have an ongoing relationship, especially with these DT patients, and seeing them every year. And actually your paper was the first time I saw that suggestion, like other than in our thoughts. So I really appreciate that.
Awesome.
As a source. And I think that would
be
an ongoing time that would be advantageous to start to address these things.
I mean, I think that's brilliant. I mean, I think that's absolutely right. And I do think, the other thing is that it is hard immediately right after getting an LVAD if they are doing really well. Right. It's like, whoa. Whereas if they're already kind of, sick and, facing this decision, I think at that point, sort of planting that seed to just understand, so it's not like the first time they're hearing it is after they've gotten it. It's like, well, wait a minute, this is supposed to fit. And now you're talking about,
Yeah.
It's not an easy solution, but I think that, again, the more frequent interface they have with palliative care, the better. And then also it helps to sort of decouple this, unfortunate association with like palliative care involvement equals dying.
Yes. Yes.
And I think that's really a very harmful perception that is, again, there's sort of this like tautology, right? It's like people think that, so they don't involve palliative care until people are dying. And so, yes, effectively, like that is the case, but it's because it's a self-fulfilling prophecy.
Yes, exactly.
Not because that you're not capable of providing excellent palliation, in patients with cancer, for example, who are undergoing active treatment, but who are dealing with a lot of symptoms. And that actually is something that I will say our cancer center does well. A lot of our patients are undergoing active cancer treatment, but also see a palliative care specialist.
Yeah.
Like that, to my knowledge, in heart failure, for example, where I think it would make a lot of sense to, again, integrate you more earlier and more often, so that, that's part of the care of patients with advanced heart failure, rather than like, oh, well, it's just the last resort we use when we can't offer anything else. Because then, of course, we're constraining your ability to intervene. And in fact, you guys have a lot to offer. Again, I don't need to tell you this, but and then it also doesn't carry this weight of like, oh, well, palliative care is a euphemism for we can't do anything else, and you're dying.
I think how you described early on in the paper LVAD, DT LVADs as a palliative therapy, like just kind of saying like, this is for your symptoms.
Right.
That could probably change a lot of stigma, to start thinking of it as a palliative measure from the get-go, rather than, oh, we'll talk to you when you're imminently dying.
Right.
But
and again, just like in the cancer space, there's there's palliative chemo, right? It's like there's palliative radiation palliative surgery to debulk. Like, we're not aiming for a cure, but we're still using aggressive treatments because they have palliative benefits with respect to quality of life. So, again, it's sort of not this like neat little dichotomy of like curative versus palliative. There are a lot of interventions that kind of take up both spaces. And thank you for illustrating that and pointing that out so eloquently. I really appreciate your comments.
Thank you so much for joining us today.
Of course.
All right. Hey, we appreciate you hanging out longer with us. This was incredibly valuable.
Yeah, my pleasure. Well, I really appreciate you, and this has been a wonderful opportunity. So thank you so much.
All right. Have a great weekend, everybody.
Bye.
Take care.